ONtheGo Podcast.
The potential of future surgical techniques, augmented with biological factors out of the orthoregenerative space to treat early OA. Some cool approaches with great translational potential may be available in 2040. Let's find out more with Dr. Christian Lattermann, Chief of Sports Medicine and Director of Cartilage Repair Center at Mass General Brigham, and Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima, and this is On The Go, the podcast all around orthoregeneration.
Taka already introduced our guest for today, and I'm also happy to be talking about early OA in 2040 with Dr. Christian Lattermann, MGH Brigham's. So it's going to be a great podcast today. But without further ado, I'm going to start with some questions that will not be part of the early OA in 2040. And that is, Christian, how do you drink your coffee usually? How often and how much?
Well, that's a really good question, and you kind of told me they were going to ask that. I have to tell you, I actually hate coffee, but that doesn't mean I'm not drinking it because I do enjoy the effects of it, but I just don't like it. So I drink it with a lot of milk and with some sweeteners.
So do you usually start the day in the hospital with coffee with a lot of milk then to get this day started and running?
Yeah, and there may be, there's now more modern things to increase your caffeine intake. So there could be an energy drink somewhere in the mix too. Not in the coffee, but
yeah,
to start the day.
Somewhere during the day that you get a Red Bull or some alternative to get you going.
Yeah, something like that, exactly.
All right. And what's your favorite place then during the day to just have a 10-minute pause or interruption from the day to drink that energy drink or coffee with? Where do you relax?
To tell you the truth, I don't have the luxury to find a favorite place. I think the place where I basically get the most time by myself is probably my car when I'm transitioning between places.
Mm-hmm. So is that during the day that you travel from one hospital to the other within Boston, or?
Yeah, it happens quite frequently. I have multiple locations, and typically I'll transition at least once a day between locations.
Mm-hmm. Is it also to the sports field to see some athletes on the field, or how does that look like?
Yeah, that I'm more oriented towards research, so I don't actually do professional team coverage, so I don't have that aspect to worry about. But I have different campuses that I do my work on, and so there's some transition there. That is on most days of the week I'll do that.
That's good to hear, and I think you already mentioned that you're also focused a lot on research, and we're gonna talk to you about that, about early osteoarthritis in the year of 2040. So we're gonna take a perspective of how that is in your eyes today and how that will be in some couple of years. To pick your brain about your thoughts on that. But first, to get into the topic, what is in your eyes the definition of early osteoarthritis?
Yeah, that's again a very good question. It's a difficult question because osteoarthritis traditionally has always been looked at as basically what you see on X-ray, right? This is what you do a total joint for. And we have kept that astutely different from what we call early degeneration, which we deal with when we are doing cartilage repair procedures. And to tell you the truth, the driver behind keeping those terms separate was really mostly insurance-based driven, because in the moment where you say the bad O word, insurances will tell you can't do cartilage repair. And in the moment where you want to do cartilage repair, basically you have to call it cartilage degeneration. I think this is not only artificial, but it's also completely wrong. Because osteoarthritis is really a process that starts at the initial time of injury to a joint. And we have done quite extensive work on this over the last decade or so. showing that even a simple, relatively straightforward ligament injury to a joint can already start the process of basically cytokine-driven degeneration of your articular cartilage, and that is basically the beginning of osteoarthritis. So in my mind, early osteoarthritis really starts at the time of joint injury and is a process that doesn't stop until the joint is basically done. Question is, what can we do to delay that process, and what can we do to manage that process without it becoming symptomatic to the patient?
Yeah, so you, I guess that's a clear answer on what early osteoarthritis is in your eyes. And you already mentioned some information about the stages. Just getting a bit deeper into that, in a previous webcast that was also hosted by the ICRS on early OA, the road to hell, you mentioned that there's a number of types of changes that are involved in the development of osteoarthritis or early osteoarthritis. Could you maybe give us some insights in which ones these are and how they develop and have their relationship with the development of osteoarthritis?
Yeah, so what happens is after an initial joint injury, you will, let's take a concrete example. Let's take an ACL injury, right? You have a 15-year-old who tears his ACL doing whatever sport it is they want to do. When you look very carefully what happens in these first 2-3 weeks after the injury, typically before they get their surgery, you will initially have an acute inflammatory response. This is why they are hurting. This is why the knee gets swollen. There'll be a hemarthros inside the knee. And within actually 48 hours, you'll see that there's a significant increase in fairly aggressive inflammatory cytokines. Things like interleukin-1, TNF-alpha, and others are basically being pushed into that joint through an inflammatory response in the synovium. The problem is that that inflammatory response really does not get controlled back down to normal. Right, so if you're looking at the inflammatory cytokine profile, what you'll see is that over the course of the first 4 weeks, the actual cytokines will go down, but the secondary after effect will not. And that after effect, those are slightly different inflammatory cytokines, such as interleukin-6 and others. They will stay elevated, and they will stay elevated for months and years after that initial onset of injury. And as a consequence, if you're looking at actual cartilage breakdown products, which are basically proteins that are being released into the synovial fluid, indicating breakdown of matrix and even collagen, you'll see that over the first 4 weeks after an ACL injury, there's a massive elution of these factors into the synovial fluid, indicating structural loss of collagen in those joints. And there's some really good work that was done a few years ago by Peter Verdonk and his group on MRI, which clearly showed that also on imaging, that there's a significant loss of matrix in these first couple of months. And so the problem is that process does not stop. And why do we know that? Well, we know that because there has been a very diligent effort to look into this over several years after ACL injuries done by the Canon trial. Stefan Lohmander, Struglix, those guys up there in Sweden looked at that, and they could find that these interleukin-6 levels and associated collagen breakdown products are still elevated 5 and 10 years after the initial injury. Now, the interesting thing is the level of these cytokines and breakdown products is not directly associated with the outcome. But as a matter of fact, the disease is progressing. And that's basically what we all see. If you look at this 10-15 years after an ACL tear, you can see this radiographically. that there is changes in that joint. Whether you want to call that arthritis or not is up to you, but there will be KL1, 2, and more severe changes. And this gets worse if there's additional injuries. So the more severe the injury to the joint is, the quicker that can happen. And then there's an additional thing that is happening. And this is something that we have recently started to look into more carefully. There's a certain percentage of patients that actually do significantly worse than the other. And it's about 1/3 of patients who suffer joint injuries, specifically ACL injuries. But it's not just ACLs, it's also with knee dislocations, with patella dislocations, it's with tibial plateau fractures. So this is a generalized pattern. About 1/3 of those patients will have a fairly activated synovial inflammation response. And that is a group that my coworker, Cale Jacobs, very aptly called the inflammatoid patient.
Yeah.
And those are the ones that will actually then fairly rapidly progress towards asymptomatic knee joint. And that can happen as quickly as a year or two.
That's very clear, and I think what's interesting is that you mentioned cytokine levels are altered. Some of the interleukins are overexpressed, but we also know that maybe I could say the majority or more than 50% of the patients do not get early osteoarthritis or do not get towards the end stages of OA. Why is it so that some of them have these extremely altered cytokine levels while the others may not have these? And how does it come that there's differences between these groups?
Yeah, so that's a really good question, and to tell you the truth, I can't answer that question right now. I mean,
I was hoping you could.
No, not quite yet. You know, what am I going to do the next 10 years if I answer that question today?
Yeah, that's the
no,
thing.
but I mean, the thing is you know, the big thing. Don't forget, it was 2014 before we actually acknowledged that that osteoarthritis is an inflammatory disease. Right, so we are only about 10 years later now, and now we have understanding a lot more of the intricacies of the whole process. But I think what is important and what we are doing right now is we are trying to define the group that develops this early inflammation, this early synovitis better. And we have a couple of trials going right now where we're actually following these pretty much anybody after ACL injury to see what the ones that have this synovitis, we will detect that with ultrasound, what the actual data patterns are on those. What are their predictors? Are there particular characteristics that basically drive you in that direction? Because those are really the worst case scenarios. And it's not just injury severity that drives that. You can have somebody with a relatively straightforward, fairly simple ACL without any additional meniscus injury who develops that, just as you may have somebody who had a full-on knee dislocation and others may not.
Yeah.
So there's other factors that play a role, and we're trying to figure that out. By doing biopsies as well as fluid analyses, imaging, and then following them with patient-reported outcomes over the first couple of years to see if there's certain predictors for that. But that will take a little bit more time.
Yeah, that's we're going to be looking forward to be reading those studies in maybe a couple of years or some years. But either from the preliminary data or from your gut feeling from your scientific and clinical experience, do you have some ideas already on who are the patients included in the group who will progress to early OA and OA in the end, and who will not be?
Yeah, so I think it's a combination of factors. And if you asked me, I have from a clinical perspective, you can almost tell who the ones are going to be that are going to struggle. And you can identify a lot of them preoperatively, but it's really subtle. And it's a combination of psychological readiness, movement, early inflammatory response to the injury. And then we'll have to see what other objective factors will play a role here. But it's a particular type of patient that you'll probably find any ACL surgeon, for example, or cartilage surgeon that has done that for a few years has kind of a feeling who that is.
Yeah.
But the challenge is to really put this into data now, right? And that's really what we are trying to do, to basically describe this gut feeling that many of us develop in more statistical terms, so to speak.
Yeah, that's going to be very interesting to find out, and to find out what that gut feeling is actually based on. Could you take us a little bit by hand on what exactly you're doing in those studies, what you're
Yeah,
performing?
so what we're doing is we are basically recording all what I would consider pertinent data. So we are recording our arthroscopy findings with regards to synovitis versus not synovitis, with regards to severity of the actual chondral injuries. We are looking at patient-reported outcomes. We are looking at MRI-based factors, which are mostly morphological. We are looking at synovitis in the recovery process. We are looking at synovial tissue and do specific tissue analysis on this, as well as biomarkers out of the synovial fluid. And then we are basically developing an AI-aided mechanism to try to figure out any one of these factors is driving the end result. So that's why I'm saying this is what we are going to be doing over the next decade. It's going to take us 4 or 5 years to come up with the first true valuable data sets. But I think this is the only way you can do it, because there's so many different factors that play a role here. And it's really hard to design something like a randomized clinical trial around just essentially one single factor when you know exactly that's not the only thing that's the problem.
Yeah. So you're basically performing a big prospective observational cohort study with collecting loads of different data points, and then trying to find out what the endpoint is and which ones will develop some science and which one will not. You also mentioned that you will apply some AI models on it. How many patients are you intended to include in that? Is it something between 2,000 up, or?
Yeah, I mean, 2,000, that is probably unrealistic. We are hoping that we can collect in the 400 or 500 patients over a couple of years between quite a few of us. And to tell you the truth, that would probably be one of the larger sets that you can do these kind of analyses on. Anything smaller than that is not going to yield the data. But this is a grand old fishing trip, right? So this is the kind of research that 10, 15 years ago you would basically be thrown out of the room if you were even proposing that. Rightfully so, because we didn't really have the tools to look at it, and now we do. But at the same time, every single one of these aspects of that study has separate questions attached that are actually truly scientific questions that you can follow up individually. And this is really kind of sort of the model that we have started to implement here at Mass General Brigham in Boston, that we are answering multiple different questions at the same time. There's an overarching question, and then there's smaller questions in between, which is going to drive basically our research and our research funding.
And I think that also brings more insights into what you've described as the window of opportunity, because now it's obviously a lot about the recognition of who is who and who is not who. Could you tell us a little bit more about how this will bring insight into the window of opportunity, when this will be, and maybe how we can act on this window of opportunity?
Yeah, so this is a really important thing, right? Because it is not a good strategy. What we have done in the past is basically we have waited until it was too late. And then we go in there and say, oh, I'm so sorry, it's too late. We have to do X, Y, Z. And that's really not a great strategy, right? So we need to have a prospective strategy on some of these patients. So what's critical here is to identify those that are doing really badly early on. And so one of the focus areas of our research is to identify specifically those. This is why we do the early ultrasound examination now on these patients. to try to figure out, are you going in the synovitis direction or not? Because we do know if you do that, if you develop early synovitis, you are likely one of these inflammatory patients. That's the first thing that is necessary, is you need to identify them early, because this happens in the first 3 months. And then secondly, you need to find strategies how to address that. And we have a couple of trials that we are currently doing at different levels, not just with ACL patients, but also with patients with degenerative meniscus tears and others, where we are testing a couple of different strategies. One strategy that we are looking at is to use long-acting triamcinolone. Now, that's the strategy that you can do in an early degenerative knee with a meniscus tear, not so much in an ACL injured patient, right? This is a strategy that comes maybe in a slightly older patient who is starting to develop symptoms.
Maybe a stupid question, but why is that you can't do it in the other group and one and you
Well,
can
it's
in the
because whenever you use triamcinolone in a setting where you are relying upon bone healing, you have to be a little bit concerned what the cortisone does at that bone interface, right? And so this is why some of the early studies that we did, we actually injected triamcinolone acetonide into knees of patients with ACL injuries, and it actually worked really well in terms of reducing the chondral breakdown. But the problem is there is concerns about doing that, particularly at the time or right after ACL reconstruction because of that. There's also data in the literature that suggests that there may be a slightly higher infection rate. That is something that I think is debatable because that is data that is really based upon Pearl Diver database searches, and that's not a very accurate way to really look into that. I can tell you the 100-some patients that we did, we could not pick any of that up. Now, of course, it would be underpowered to pick this up, but even anecdotally, we had 0 infections, right? So, I personally don't think that is a big deal, but I am convinced that cortisone interferes with bone healing, and if you are putting a graft in that you rely upon the bone interface healing, is not necessarily what I would like to put into that joint at that time. So other strategies may be more reasonable here. There's strategies that, for example, play along the role of generalized inflammation to reduce generalized inflammation. And one trial that is actually being run by my partner, Morgan Jones, right now, he's just starting a trial where he's going to be using metformin. Metformin is known as an anti-diabetes drug, but it also has significant effects on a whole bunch of other systems that are designed to reduce an inflammatory burden. And that is one strategy that we are looking into. Another strategy is looking into stiffness and synovitis-related stiffness. And we are just about to start a prospective trial where we're using losartan, which is actually known out of the cardiac field because it's a calcium channel blocker, and the side effect of it though is that it reduces the activity of fibroblasts that have the ability to contract. And that is putatively the reason why some of these scar tissues basically really tighten up the joint, is because they lay down scars, and then if there's a lot of myofibroblasts in that scar tissue and they contract, that really kind of ties down the joint, and losartan potentially interferes with that. And so that's another strategy that we are looking into. And then the one strategy that seemed very obvious, which was to basically just block the early inflammation, that's something that we are probably not going to continue to pursue, because if you do that too early, you are actually stopping another process. And this is some experimental work that we do in mice, which has been really exciting, where we are looking at inflammation resolution, right? So if you think about osteoarthritis as a chronic inflammation, which it is, then you can get clues from other chronic inflammatory diseases, such as pulmonary fibrosis, such as periodontosis and others. And interesting enough here is one of the big drivers is the fact that this inflammation simply doesn't go through a process. So normal inflammatory process, if you have a regular, straightforward inflammatory process for whatever reason, it will flare up. You'll have an influx of leukocytes, you have an influx of macrophages, and then eventually what will happen, the macrophages inside that inflammation will start eating stuff, but they will also transform. They will transform from macrophages that are producing and reacting to a lot of inflammatory markers towards macrophages that then say, okay, I'm done with this now. Now let's rebuild the tissue. And it's called the M1, M2 switch, where the macrophage changes from a catabolic status into an anabolic status. And this M1, M2 switch is mediated by certain substances. That is, there's a whole bunch of different molecules involved. There's pathways involved, such as the Wnt pathway, for example. And there's also a particular group of fatty acids involved that are called specialized pro-resolving mediators. And those are very abundant everywhere in the body. And they are one of the known drivers of resolution of inflammation. And interesting enough, when you're looking into early OA in mice, when you transect ACLs in mice, and they will get OA just like humans do. And if you're looking for these specialized pro-resolving mediators, they actually have differences in their expression, and there's even sex differences. But if you substitute those at the right time, you will actually get a significant reduction in inflammatory cytokine production and also in manifestation of osteoarthritis. Now, there's hundreds of different kind of molecules that people say do that. But why I'm excited about that particular area is because it makes conceptual sense.
Yeah.
Right. It is not just a molecule of the year. It's actually an entire process that sits behind that. And I don't care if this is an SPM, what that's called Meresin or RED1 or whatever you want to call it. What I care is that the actual mechanism seems to be involved here. And that's what we are trying to go after now.
Yeah. And in the end, you can translate that back to the humans in your lab or from your lab.
And the cool thing here is that translation would actually potentially be really easy because you can actually substitute these orally. You don't have to necessarily inject them in order to get reasonable levels on a systemic basis, right? And it's a chemical reaction. It's basically, if you put more in, you'll get more out. And so that is particularly interesting about it, because if we are doing these experiments right now, if we can truly drive this by feeding the appropriate stuff, then that's a really simple translation in the human setting.
Yeah, that's gonna be very interesting. And again, we're gonna be looking forward to the results of those studies getting published. Just because we're slowly going to the end of our podcast, but I have still some questions, because we're gonna move a bit to 2040, and of course, you've already laid a very good basis of where we'll be there. But just imagine that we're in 2040. We have this window of opportunity, maybe more clear in our sense. We have some target populations that we can target in an early phase. First of all, how would this window of opportunity look like in 2040 in your eyes from a clinical setting? And what we'll be able to do in 2040 to prevent the early OA or OA as a whole?
Yeah, so this is kind of course speculative, right? And I think if you asked different entities, I was just part of a panel with a very new entity here in the US called ARPA-H, which is basically a project that tries to apply the principles that DARPA, which was a very successful military program, to try to apply that to the human setting. And they basically say they want to eliminate osteoarthritis in 6 years. Right? And the idea is you inject something magical into the joint that basically turns an arthritic joint into a normal joint, and that's it. And I think that's probably a little bit unrealistic.
Yep.
But what I do believe is realistic, that in the process of developing approaches like that, that will get to the point where we do treat the injury, whether that is replacing the ACL or fixing a fracture or fixing other ligaments or so, either in the shoulder or whichever joint it is. And then you do surgery plus. So in other words, then you basically alter the chemical environment of that joint with some sort of an approach that allows you to prevent the inflammation of the inflammatory response once it becomes chronic, and just before it becomes chronic. Because as I told you, the initial inflammation, I think, is a beneficial thing. Yeah. But then you need to sense when that turns around. And there's some really cool approaches that may, by 2040, may be available. I mean, there's some work out of WashU done by Farshid Gulag and his lab, and he has he can literally influence local chondrocytes to produce anti-inflammatory cytokines based upon loading, based upon concentrations of interleukin-1, and even based upon the circadian rhythm. You can switch this on and off at will using certain gene therapy techniques. So it could be something along those lines, or it could be just a magical substance that may be stem cell technology related. But it's going to be something along those lines that you basically, I don't think surgery is just going to be completely going away. I don't think we can just magically inject something that will just magically restore a ligament and do like the Star Wars or Star Trek kind of sort of, tricorder healing approach. But I think, we will have surgical techniques that are going to likely be more advanced than what we're currently doing, but still fundamentally the same, augmented by biological factors that could come out of the regenerative space, that could come out of the nanotechnology space. It could come out of the artificial joint space. If you ever get to the point where you have self-assembling metals, for example, that find their spot, I mean, those kind of things I can see.
Yeah, well, that gives us some great insights into what steps we have to undertake to get there. Well, on the one hand, we can't wait till it's 2040. On the other hand, we can. So that's a good way to, I guess, to end the content part on the early OA, and that's given, I think, all the listeners a lot of inspiration. Just slowly getting to the end. Some non-OA related questions for you, Christian. What is your guilty pleasure?
To tell you the truth, my guilty pleasure is outdoor sports.
Oh, yeah.
So I love to be outside, and whenever I have the chance, I'll try to escape somewhere, up into the mountains or into the water somewhere. So
hiking,
kayaking, mountain biking, you name it, all three on the weekend if I can. But that's really kind of sort of, to tell you the truth, that is the best regeneration that I can get for body and mind if I need it. So.
Yeah, very good. What is something?
And then the other thing I have to admit to,
yeah,
and that not many people know, that is gummy bears.
That's your energy, besides your energy drink that keeps you going. Yeah. And what is something that most people do not know about you that is special, or that most people don't know?
I think to tell you, I think the one thing that most people are surprised about is that I can go to fancy dinners and everything, but to tell you the truth, having a roadside or having a burger somewhere on the side of a river is to me is probably much more delightful than the most fancy dinner you can have anywhere. I live in both of these worlds, but if I could, I'd be sitting somewhere on the side of the river and just think about stuff.
Very, very good. To brainstorm about 2040 and early OA. All right, and then the last one for the listeners who want to get published in the orthoregenerative world. What is your best or number one tip that you would give them to make more chance on a successful publication or a successful research project?
Be relevant. Stop chasing favorite molecules and theoretical ideas that have no clinical relevance. I think that's the most important thing. Is none of the basic science research that is not tied into an actual clinical application has really moved us far ahead. I think the translational aspect of what we are doing is the most important aspect, and don't forget that.
All right. Thanks. Thank you very much, Dr. Christian Lattermann from Boston. I think we've all enjoyed this podcast, and I guess many people have loads of questions and opportunities to get inspired by this podcast, and hopefully you all listen to the next one. Thanks.
Well, Jari, thank you very much. It was my pleasure, and I always like to talk about this.
So.
Outdoor sports as regeneration for body and mind. Probably a great idea to not only keep patients, but also doctors healthy. Stay tuned for more content at my.on-foundation.org. Thank you for listening and have a great day.